Well, ladies, now we're going to move over to the options for you. And to do that, let's speak with Dr. Samir Ahmed. Good morning. How are you?
Good morning, Sandra. How are you?
I'm blessed. And of course, ladies, he's the vascular interventional radiologist at MIMIT. And he's going to talk to us today about the non-surgical options, because I know plenty of you, and we hear it all the time, that the first thing people say is, or some doctors have said, are hysterectomy. Well, today we have some non-surgical options, non-invasive options to share with you. So let's get started with Dr. Ahmed.
Excellent. Thank you,
First
Sandra.
question.
I'm going to try to share my screen here.
Okay, perfect.
Let's see if this works.
Yay.
Can you guys see it?
Yes,
Okay,
absolutely.
excellent. So Senator Hunter actually brought up a great point. You know, there are a lot of disparities for African American women, and a third of African American women will end up with a hysterectomy. And I think the unfortunate part is the lack of information out there on what are the options. And a lot of physicians are not aware of all the options. And I think, patients often go to their gynecologist for advice on how to deal with uterine fibroids. And they are provided with a set of options such as dietary therapy, hormonal therapy, and then some of the procedures that gynecologists are very comfortable with because they do it themselves, such as myomectomy and hysterectomy, and I can talk a little bit more about that. But a lot of gynecologists are unfortunately just not aware of uterine fibroid embolization, even though the American College of Gynecology has given this treatment, fibroid embolization, its level 1 designation. So it's considered a first-line treatment for treating uterine fibroids. So this is a nice graphic. It shows the spectrum of treatment. So you have there's a lot of information out there on the internet about what you can eat, how you can modify your diet to help with uterine fibroids, and there's just not a lot of good data to support dietary management of fibroids. There's hormonal therapies such as Lupron, which is basically a pharmacologic way of inducing menopause. So that is one option out there. But again, it's a very extreme change in one's lifestyle. And then on the other end, you have these surgical options such as open hysterectomy, laparoscopic hysterectomy, myomectomy, which can also be done open and laparoscopic. So hysterectomy is, of course, taking out the entire uterus. It involves a large surgery. So there's a large incision that's made to open up the belly as well as the pelvis. And then the entire uterus is cut and taken out. Of course, there are a lot of risks associated with any type of open procedure, especially one of this magnitude. There's a high risk of bleeding, infection. There is a long hospitalization that's often associated with hysterectomy, up to 5 days. And the other thing is that, the uterus is very precious territory.
Mm-hmm.
So there's a lot of, precious organs and structures that are next to the uterus. For example, the connection between the kidney and the bladder, which is called the ureter, runs right along the uterus. So you can imagine that if you're doing this large surgery, that structure is at risk for being damaged. And I've seen, from my experience, I've seen many women end up with damaged ureters, and then they end up living with a tube coming out of their back because they can't pee normally. So the hysterectomy, again, I don't think it's a procedure to be taken lightly. Again, it's a pretty involved surgery, and again, very high risk of bleeding, infection, and damage to adjacent structures. Myomectomy is another option. So essentially, a myomectomy is where you try to target some fibroids for removal. So essentially, you go in and you shave out whatever you can of the fibroids that are essentially, very accessible.
Okay.
But a lot of fibroids are not accessible because most of the fibroids, the vast majority, actually live in the meat of the uterus, which is
Mm-hmm.
the inner musculature of the uterus, and those are very hard to get from doing a myomectomy. And again, it can be an open procedure or a laparoscopic procedure, but it is an involved surgery. It requires hospitalization, increased risk of bleeding, infection, etc.
Sure.
And then we have uterine fibroembolization, which is a minimally invasive option. So I'll
Mhm.
talk more about that. So let's see if I can go to my next slide here.
And that's the UFE treatment, correct?
The UFE treatment, uterine fibroembolization.
Mm-hmm.
So let me give you an example of what I'm talking about. So when we're talking about open surgery versus minimally invasive options, the principle, before I move on to the slide, the principle for a uterine fibroembolization is that fibroids are very vascular structures. Um, they're, uh, they essentially grow because they try to suck in as much blood flow as possible, and that's why they also are associated with heavy bleeding. You can consider fibroids to be kind of like the weeds in a garden. So, the uterus is like a garden, the garden of life. And the fibroids are the weeds in the garden. So when you're trying to treat weeds in a garden, do you get rid of the garden, or do you spray the weeds and try to do a very targeted therapy? So that's what we're doing here. So uterine fibroembolization is a very targeted therapy to get rid of the weeds, the fibroids.
Okay.
So I really like this slide because it gives you a sharp contrast between the options that are available. So you have hysterectomy versus uterine fibroembolization, which is done through a little incision in the wrist about the size of the tip of a pen, something you
In
can
the
put a
wrist.
band-aid over.
So this goes through the wrist.
Yes. So we go
Okay.
in through the wrist. We go into what's called the radial artery. If you hold out your hand and feel your pulse, the pulse that you feel is actually through the radial artery, and we want to go into that artery through a very tiny incision, about the size of the tip of a pen, something you could put a band-aid over, and through that little tiny artery, we go in all the way down to the main supply to the uterus, or to the fibroids, as you say, which are the uterine arteries. And there's one uterine artery on each side. And we go in and we specifically target the areas that are supplying the fibroids and shut down that blood supply in order to kill the fibroids. So a hysterectomy, again, involves a big abdominal incision. It's costlier, it's painful, it's more expensive. And when we say expensive, we don't just mean, the dollars and cents, but it's actually expensive and takes a toll on the body.
Mm-hmm.
And again, there's higher risk of complications, and it can be quite debilitating if any type of complication occurs. As opposed to uterine fibroembolization, it's easier, better, faster, and certainly less costly because you're not staying at the hospital for 5 days. You're not getting admitted to the surgical floor, etc. You're not exposing yourself to all the other bad things that can happen at the hospital, for example, infections, MRSA, etc. So it's a outpatient procedure. You come into one of our outpatient vascular centers where we do this procedure, have the procedure done, and you're back home the same day. If you come in at 8 a.m. to have the procedure done, you're eating lunch at home. That's how quick
Wow.
you're back.
Okay.
So let's see. So yeah, this is what fibroids look like, and for a hysterectomy, big abdominal incision, and this is the fibroids within the uterus are obviously very prominent, and they're being taken out. As opposed to uterine fibroembolization, again, we go in through the wrist. We use our special image guidance to see exactly where we're going into the fibroids, the vessels that are supplying the fibroids. We take our special catheters, our special devices, to specifically target the fibroids and the arteries that are feeding the fibroids, and we stop the blood flow. So here you can see on the bottom right, there's an example of a pre-image and a 6-month post-image. So the fibroid is lighting up. I don't know if, can you see my cursor at all?
Yes.
Okay, perfect.
Hmm.
So you can see the fibroid lighting up here. It's large. It's pressing down on the bladder. So this structure right here is actually a bladder, and you can see that the fibroid is so large that it's pressing down on the bladder, and that's why women experience frequent urination and sometimes incontinence as well.
Mm.
And then after 6 months post-procedure, the fibroid is essentially gone. So we can
Gone.
take a 13, 14 centimeter large fibroid and shrink it to the size of a pea, essentially, by doing this procedure.
That is amazing.
Let's see if I could, I have a, so this is an excellent slide too, because it gives you, you know, exactly the perspective of the patient. So at the end of the procedure, this is all you have. You have a little tiny incision in your left wrist, and there's this band that we use to close essentially the incision at the end. This band stays on for about 30 minutes after the procedure. We take off the wristband, and that's it. You can walk around, you can go to the bathroom. If you're feeling any pain after the procedure, you have full range of motion available to you. And then this is, you know, when we're talking about education, you know, it's really a privilege here to be part of this conversation and to be a panelist here, because I think education is the most important thing when it comes to taking care of our body.
Mm-hmm.
And unfortunately, there's just not that much education out there for uterine fibroembolization. This procedure has been around for a very long time. It's been around for decades, actually, and the research on it is level 1 evidence, meaning it's gone through clinical trials, etc. It's considered a first-line treatment for treating uterine fibroids. And this is back in 2004, news from CBS when Condoleezza Rice had her fibroids treated with uterine fibroembolization. And now we're in 2020, and still a lot of women, the only options they're given are hysterectomy and myomectomy, which is just, you know, incredible to me. Talking a little bit more about the fibroid procedure, embolization procedure, we can go through the wrist like I showed, but we can also go in through the hip artery. The reason we prefer the wrist, and it's become well established that the primary way to do this procedure is through the wrist, is because of the decreased risk of bleeding, decreased risk of infection, and also the rapid recovery. So like I said, within 30 minutes, you're up and about, you're walking, you're eating, drinking, you know, you're essentially back to your normal self in terms of activity. And if you're having, you know, any type of pain, control with medications that we get. For the procedure itself, we do twilight sedation. So twilight sedation means that through a little IV in your arm, we're going to give you a few medications just to make you very comfortable during the procedure, so you don't have any type of pain. Essentially, from the perspective of the patient, it's going to feel like you're getting a good night's sleep. And then within 20, 30 minutes after the procedure, you're wide awake. You know, you're essentially back to your normal self. And the procedure itself is essentially painless. There are, you know, patients who have pain after the procedure, and we give prescriptions for medications to help control the pain. I always tell women, expect to have some pain after the procedure, especially for the first 3 days, but within a week, you should be back to your normal self, back to your normal activities, exercising, back to work, and, you know, whatever you need. I've had women who, after the procedure, the next day, they're back to work. Some women prefer to have this procedure done on a Friday so that they get the weekend off, and by Monday, they're back to work, they're back to their normal activities. So the recovery is just very, very quick. A lot of women ask, you know, what are we putting into the artery to stop the blood flow? So this is what it is. It's called an embolic agent. It's essentially little tiny beads. They're gelatinous beads. they look exactly like this, and they're inert, meaning they don't have any type of reaction with the body. They don't go anywhere else besides the uterine fibroids because they're specifically sized to go into the arteries that are specific to the fibroids, and the rest of the uterus is completely protected from these beads and from any type of harm.
Okay. And Doctor, before you move forward, I just want to remind the ladies that we will be taking your questions. I see we have about, we have several coming in, but just hold on. We got a Q&A section right after this. So please submit your question at the Q&A, and we'll get to your questions shortly.